video we are going to discuss the hormones acting on the kidney. This is the diagram of the nephron of a kidney, and this is the glomerulus. This is the afferent arteriole which form the capillary plexus, and it leaves the glomerulus through the as a efferent arterioles. So the glomerulus extend further as proximal convoluted tubule, and then it forms the loop of Henle and form the descending limb of loop of Henle, and then ascending limb of loop of Henle, and then it forms the distal convoluted tubule, and finally it ends as a collecting duct. First of all, we will discuss the atrial natriuretic peptide. This is the hormone which is secreted in response to the increase in the atrial pressure. When the blood volume increases and blood pressure increases, it causes stretch on the atrial wall, and atrial pressure increases, and the cells, the stretch and the cells in the atrial wall detects this increase in the pressure, and it causes and releases the hormone atrial natriuretic peptide. This ANP or atrial natriuretic peptide causes increase in the glomerular filtration rate and increased sodium filtration with no compensatory sodium reabsorption in distal nephron. So net effect is sodium loss and volume loss. It causes the vasoconstriction of the efferent arteriole, due to which net filtration will be increases, GFR will be increases, but there is no reabsorption of the sodium from the distal convoluted tubule. So net effect is sodium and volume both are decreased from the plasma volume. Then comes the angiotensin II, which is activated by the renin angiotensin aldosterone system, and final product is angiotensin II, which is formed by the angiotensin 1 and then the angiotensin II is the active form. It is synthesized in response to the decrease in the blood pressure, and it causes efferent arteriole constriction, same as the ANP does. So both of these, ANP and angiotensin II, causes the increased glomerular filtration rate via constriction of the efferent arteriole, but the difference is it causes compensatory sodium reabsorption in proximal and distal nephron. While in the case of the ANP, there is no sodium reabsorption in the distal nephron, but angiotensin II not only increases the glomerular filtration rate and fluid flow for fluid filtration, but it also causes compensatory sodium reabsorption in proximal and distal nephron. So the net effect is preservation of the renal function, that is increased fluid filtration in low volume state as the BP is decreased, with simultaneous sodium reabsorption both proximal and distal to maintain circulating volume. Angiotensin II is activated when the blood pressure drops, while ANP is increased when there is blood pressure increases and atrial pressure is increased. Then comes the aldosterone, which is activated by the same angiotensin aldosterone system via which angiotensin II was activated. Angiotensinogen is converted to angiotensin 1 via renin, and angiotensin 1 then further is converted by the angiotensin converting enzyme into angiotensin 2, and then angiotensin 2 activates aldosterone by acting on the adrenal gland cells. So aldosterone is mainly activated by the angiotensin 2, and is secreted in response to the decrease in the blood volume via angiotensin 2 and increased plasma potassium concentration. So it is activated by, first of all, by decreased blood volume and increased plasma potassium concentration. So it causes increased sodium reabsorption and increased potassium and hydrogen secretion. Then comes the ADH, which is also called as vasopressin hormone. It is antidiuretic hormone, so it affects as the antidiuresis. secreted in response to the increased plasma osmolality and decreased blood volume. It binds to the receptors on the principal cells and cause increased number of evaporants and water reabsorption. Increased reabsorption of urea in collecting ducts to maximize the corticopapillary osmotic gradient. And the last hormone acting on the kidney is parathyroid hormone. It is secreted in response to the decreased plasma calcium and increased plasma phosphate. So as the factors activating it are the decrease in the plasma calcium and increase the plasma phosphate. So it will act to increase the plasma calcium concentration and decrease the plasma phosphate concentration. It also is stimulated by the decrease in the vitamin D concentration. So it causes increased calcium reabsorption from the distal convoluted tubule. Here it causes the parathyroid hormone acts and it causes increased calcium reabsorption and decreased phosphate reabsorption from the proximal convoluted tubule. It acts on the distal convoluted tubule to increase calcium reabsorption, and it acts on the proximal convoluted tubule to decrease the phosphate reabsorption and increases the vitamin D production, that is 1,25 dihydroxycholecalciferol. The parathyroid hormones effect on the intestines is increased calcium and phosphate absorption from the gut via vitamin D. So in the gut it increases both calcium and phosphate, but in the kidney at the proximal convoluted tubule level it decreases the phosphate reabsorption, and in the distal convoluted tubule level it increases the calcium absorption. So this was the whole effects, the whole mechanism of hormones acting on the kidney. These are the hormones ANP, angiotensin 2, parathyroid hormone, aldosterone and ADH. These hormones act on the different parts of the kidney for water absorption or water secretion and sodium regulation at different parts, and different hormones increases sodium reabsorption and increases sodium secretion. Same some increases potassium and hydrogen secretion, some decreases them. So this was the whole mechanism of different hormones acting on the kidneys.